Kia ora, and welcome to this presentation in which we discuss the ECG recognition of acute myocardial infarction in other ACS presentations. There are two main topics for this presentation. The first is going to review our existing knowledge when it comes to recognizing the ST segment elevation in acute myocardial infarction. The second area is going to look at the worrying ECG signs that indicate an increased risk in terms of an ischemic injury or other adverse outcomes that are associated with ACS. The king in any pattern recognition of cardiac injury is regionalization. And the rule of thumb is to base the reading of the ECG on the regional distribution of the leads around the heart. In other words, we read the ECG utilizing the lead groups rather than any particular layout on the ECG printout itself. The recognition of the signs of acute myocardial infarction and the acute cardiac syndromes rely on one or more contiguous leads showing signs. So the lead group approach is the strategy we use to maximize recognizing whether the specific rules that we have to rule these conditions in are met or not. From a diagnostic perspective, the significance of ST segment elevation in lead AVR has become more prevalent. Now, once this was considered to be the other lead and was the orphan on the printout. However, its association with the occlusion of the left main coronary artery and or multi-vessel disease has come to the fore with recent research. So this is not a STEMI equivalent. However, researchers have linked ST segment elevation in AVR that coexists with ST segment depression and other leads to higher mortality and a higher incidence of adverse events. When it's coupled with anterior changes diagnostic of STEMI, it's prognostic for a poor outcome. Let's have a look at peaked T waves. In the first few minutes following occlusion, the initial stages of the injury drive changes to the repolarization sequence. So as a general rule of thumb, most of the changes we're going to be looking at are going to affect elements of the waveform related to the repolarization sequence. That is, it's going to affect the ST segment or the T wave. The changes that affect the electrical baseline do not happen immediately. Hence, the ST segment changes may take several minutes to occur. But before these changes happen, we get hyperpolarization, and this drives an increase in the T wave amplitude. So this is part of the evolution of acute myocardial infarction, and hyperpolarization will eventually resolve, and the ST changes that we're very familiar with become more and more apparent. Now, beyond the 4-hour mark, the ST elevation is going to start to settle, and we're more likely to see the development of Q waves. However, the hallmarks of a hyperacute T wave are that they are tall, that they are narrow, and that they alter with evolution. In terms of ST segment elevation, let's remember that between 1/3 and 1/2 of people that suffer an acute myocardial infarction are going to be transmural or full thickness, which means between half or 2/3 of the people aren't going to see the classic changes that we associate with a STEMI. Most of these events are going to reproduce a repolarization variant that alters the position of the isoelectric line by making the resting voltage more positive within the damaged area. Now, this is most evident as repolarization occurs, making the ST segment appear higher than the baseline in the unaffected regions. As it is specific to the damaged area, it's going to produce these regional rather than global ECG changes. Researchers have shown that the following rules are diagnostic of an acute myocardial infarction, and troponin testing is not required before activating the revascularization pathway. So, if there is 1 or more millimeters in 2 or more contiguous limb leads, or between V4 and V6, then it's a STEMI. And if it exceeds 2 millimeters in 2 or more contiguous leads between V1 and V3, it is also a STEMI. The wall of the heart that is opposite the damaged area is going to see the same event, but it's going to see it from the reverse angle. And in that case, the ST segment is going to appear to be depressed. Researchers have debated the relevance of these changes. However, they do increase the confidence we have in recognising STEMI. So investigating for reciprocal changes using a pale mnemonic is part of our recommended process in terms of ECG interpretation. And while we're discussing systematic interpretation, the most often missed STEMI are those that affect the lateral walls of the heart. In these cases, the ST deviations are quite often subtle and don't activate concern based on a quick pattern recognition process alone. A very conscious review of all the regions is recommended, followed by examination of the reciprocal leads. Further ECG evidence of a transmural AMI is the development of a pathological Q wave. The electrophysiological principle behind Q waves is linked to the principle that an electrical signal travelling towards an electrode will cause a positive deflection of that lead on an ECG. Now, there's a blockade being caused by the infarction, and on its own, because there's no real electrical activity happening in the centre of that, it wouldn't produce any deflection at all. In other words, it would be a flat line. However, the electrodes closest to the infarcted area continue to see through this infarction as if it were a window. And so what they see is the remaining signals from the heart, which will always be moving away from the infarcted area. The net result favours a negative deflection on the ECG for those leads. Now, because it starts at the early stages of ventricular depolarization, the QRS starts with a negative deflection. Furthermore, the ventricular signal's amplitude is quite significant, and so this favours quite a deep Q wave. So that results in the first of the two defining characteristics of a pathological Q wave, that is, its amplitude. A Q wave having an amplitude greater than 1/3 of the height of the associated R wave is defined as pathological. The second defining element of a pathological T wave is in the width. Now, because the transmural infarction will prevent transmission through the Purkinje systems of the affected segment, the depolarization wave is going to move more slowly, and so it's just going to elongate the Q wave. So let me recap. The defining characteristics of a pathological T wave are an amplitude less than 25% of the preceding R wave, or the duration of the Q wave exceeds 0.04 of a second. So this brings us to the second part of this, and we start to look at the signs that are associated with the non-STEMI or the ACS spectrum. So we're going to look at anterior R wave transition, ST segment depression, and alterations to the T wave. Alterations in the direction of current flow during depolarization of the anterior aspects of the heart can alter the QRS vector in the chest leads. Now, in the normal circumstances, the predominant vector moves towards the electrodes that are from V3 to V6. This results in the R wave being the principal element of the QRS in those leads. The transition zone is the leads that show a switch between the S wave being more prominent and the R wave becoming the dominant wave. And the normal zone of transition is anywhere between V2 and V4. Generally, the transmission is normal if the R wave in V4 is taller. So early transition is when the R wave is dominant before you get to V2. We'll talk about this in separate presentations. The normal transition is between V2 and V4. And if we talk about late transition, that would be where we have a dominant S wave in V4 or beyond. Now, where we see these, it can be a sign of a previous anterior injury, such as an infarct. It might be a sign of an acute cardiac syndrome, or it might be a sign of hypertrophy. And you're going to have to use a certain amount of clinical differentiation to know which of these it is. Right, this brings us to the next topic we're going to look at, which is ST segment depression. So these are associated with a non-STEMI, with ischemia. It can be caused by mechanical strain, and although not as common as it used to be, could be caused by some drugs. Again, it's going to require some clinical differentiation to pinpoint the most probable cause. The ECG characteristics are going to differ slightly between the causes as well. So paramedics are going to have to consider the morphology of the ST changes. They're going to have to look at the distribution of the ST changes and concurrent factors such as access and QRS amplitude to make a final determination. But for the rest of this segment, we're going to concentrate on the changes that are associated with acute cardiac syndromes. So the changes associated with an infarction or an acute cardiac syndrome reflect a disruption of subendocardial repolarization around an injury that's not transmural, so that's a partial thickness MI. The ischemic changes are reversible, and an example of this would be the ST depression caused by the relative ischemia secondary to a tachycardia. As the tachycardia resolves and the tissue recovers, we would expect to see ongoing resolution of the ST segment depression, although this can take a little time for it to normalize. The worrying signs associated with ST segment depression include ST segment elevation and AVR. That's always taken as a poor prognostic factor. I'll make the point now that it's not diagnostic of an AMI, but it certainly adds evidence to the fact that urgent consult is required. So without troponin testing, differentiating ST depression between reversible ischemia and a non-STEMI is problematic. And it's just safer to assume and to manage all cases with worrying ST depression as possible infarcts until it's been proven otherwise. The hallmark of ischemia or infarction-based ST segment depression is a downsloping of the initial part of the ST segment. Infarction is more likely if the T wave is inverted in the same lead. Now, should the ST segment be horizontal, ischemia is also a very likely culprit. This brings us to an investigation of the T wave changes. Now, the T waves represent the bulk of the ventricular repolarization. They're normally positive in most leads, with the notable exceptions of AVR, and in some people also lead 3. It's not impossible for them to be negative in some other leads, but those are the two that are more likely to have isolated T wave inversion. Normally, T waves are proportional to the QRS, and this is translated into the height of the T wave being 25% or less than the largest deflection in the QRS. As a rule of thumb, on most ECGs, it means that they're going to be less than 5 millimeters tall in the limb leads and 10 millimeters tall in the anterior leads. But where there are large QRS complexes, the percentage rule is probably going to be the more appropriate guide. Isolated T wave inversion is really worrying unless there are other perturbing signs such as ST depression or ST segment elevation on AVR, or there are alterations across contiguous leads. Other things that can alter the T wave, such as left bundle branch block, paced rhythms, left ventricular hypertrophy, or other mimics, require a great amount of diagnostic accuracy, and this is always enhanced by looking for reciprocal changes. The alterations in T wave morphology that are caused by this ischemia are primary changes. They are manifestations of something that has altered the action potential of the affected area without changing the underlying sequence of depolarization or repolarization. Now, this contrasts with secondary changes such as those that occur with left bundle branch blocks, where the T wave alterations are a direct result of the block having altered the sequence of events as opposed to the nature of the action potential itself. So, these primary patterns that are caused by ischemia and infarction are very similar in that the T wave is inverted in contiguous leads. It remains narrow and it remains symmetrical, and the preceding ST segment may be depressed or have a concave appearance. The last thing I wanted to mention about T waves is that they can develop later in the evolution of an acute myocardial infarction, and they will normally coincide with the formation of Q waves, or they're going to occur in leads that have initially demonstrated ST segment elevation. Now, if this is the case, we're looking at the later evolution of an AMI. So to finish this section off, we'll just look at briefly the other causes of inverted T waves. Now, I'm not going to go into this deeply. There are separate sessions to cover this. But where we're looking at inverted T waves, the same as when we're looking at ST segment elevation, we need to think, is there a bundle branch block? and normally the evidence of that is going to be with the width of the QRS. We have to think about whether there's been a CNS insult, but these normally produce a very wide T wave and are going to have a clinical pattern that's not going to look like ACS. There are the strain patterns, but normally there's a clinical history of heart failure, or the diagnosis is going to be indicative of some sort of ventricular overload type problem. Sometimes they can persist as a juvenile pattern because they're not unusual in children, but normally you need another ECG to compare with to know whether this is the case. So the last one we're going to look at is Wellens sign. So this is a form of T-wave inversion that's very specific to one of two conditions. It normally happens during reperfusion. So should you be giving thrombolytic drugs to somebody, it wouldn't be unusual to see this particular pattern evolve. The other time that it's well known to occur is when there's severe stenosis of the left anterior descending artery, and it may not have progressed yet to the stage of an infarction, but is definitely on the acute coronary syndrome spectrum and has a poor prognosis if it's not managed urgently. The key indication of a Wellens sign for either of these two occurrences is that you have deeply inverted or biphasic T waves where the terminal section of the T wave is negative and that they persist when the patient is pain-free. This brings us to the end of the presentation. Now we've got some more exercises to run through on the block courses to help with this. The hallmark for an acute myocardial infarction is ST segment elevation, but we know between half and 2/3 of the people that are having an AMI are not going to produce these changes. On top of that, even 50% of the STEMI patients have inconclusive findings with the first ECG that's taken. In terms of acute coronary syndromes and non-STEMI, patients require biological markers such as troponins to identify whether or not they're having an infarct. In the short term for paramedics though, we can raise the level of suspicion by looking for those subtle T-wave changes such as we see in the Wellens sign or the T-wave inversion where it shouldn't be, particularly when it's in contiguous leads. We know that poor R-wave progression can tell us about anterior ischemia. And we know that adverse events can be associated with ST segment depression, particularly where they're coupled with ST segment elevation and AVR. Lead placement is paramount for reliability in terms of these signs, so we're able to look for regional and contiguous changes and look for any reciprocal changes at the same time. Now, I will remind you, there are other presentations that will cover off on the STEMI mimics and the other things that can confound this information, but I hope in the short term this has been useful in terms of looking for the more subtle signs associated with acute cardiac syndromes. Ka kite.